take your seats. We're one short of a quorum, so we can't move the bill or the amendments, but if Representative Schoen, welcome to the committee, and if you would just like to start presenting your bill, and I know you have an amendment with that, but why don't you just start with the bill in general?
All right, thank you, Mr. Chair. Mr. Chair and members, I've introduced House File 455 for your approval to support new innovations in the recovery and support for individuals who are using public-funded Consolidated Chemical Dependency Treatment Funds, also known as CCDTF. These funds are currently can only be used for treatment by a Rule 31 provider. In 2009, the legislature passed a bill that allowed 2 pilot projects to use the CCDTF funds flexibly to provide additional supports for individuals who have severe chemical dependency. The pilot project participants experienced an increase in housing stability, employment, and sobriety. The counties also saw a decrease in detoxification from the participants. And I have a couple speakers here today to testify about what they've learned from the pilot projects, and we'd like to request statewide implementation. And so, Mr. Chair, would you like to start with the testifiers? Do you want to talk about the amendments for the bill?
Why don't we start with the testifiers?
All right.
Mr. Chair, members of the committee, my name is Cindy Rupp. I'm a division manager with Washington County. I have oversight of our chemical health services. Thank you for the opportunity to address the committee this morning. In my testimony today, I'm speaking in behalf of both Washington County, the Region 10 counties, as well as the Minnesota Inter-County Association. Thank you to Representative Schoen for sponsoring House File 455. This bill authorizes the Department of Human Services and interested counties the ability to work in partnership to augment the current chemical health delivery service. The services in this bill help individuals to access additional resources and support in order to improve outcomes such as sobriety, employment, and stable housing, which are key factors in recovery. This bill allows statewide implementation of components of a recovery-oriented system of care, which research indicates provides the best opportunity for individuals with chemical dependency to engage in long-term sobriety. Participation in the program is voluntary. Eligibility requirements are consistent with what is currently required for the Consolidated Treatment Fund. We have also additional requirements, such as a minimum of 2 treatment episodes within the last 2 years of admission into the program, an ER admission, a detoxification, or hospitalization related to their substance abuse issues can also be substituted for one of those treatment episodes. These services are currently not available in the existing Consolidated Treatment Fund. Treatment services are currently the only thing that can be paid for through the fund, and it must be by a licensed Rule 31 provider. This bill allows us to use that fund more flexibly for a subset of the population that is eligible for treatment in order to provide them a more support and wraparound services. Washington County and Region 10 in southeastern Minnesota participated in a pilot project authorized by the legislature in 2009. Those projects were models for this bill. The pilot will end July 31st, 2013. The services the pilot provides include a navigator, peer and housing support, a rent subsidy for up to 3 months, supported employment, and independent skills development. The role of the navigator is to meet with the person, do an assessment, identify what their needs are in a holistic manner. And those needs include individuals who may need some kind of medical services. I'd just like to share some of our key outcomes. We had 28 clients enrolled in the first 2 years of the program. Before enrollment, they had 72 days of detoxification. In the 2 years of participation, that admission fell to 17 days. In Washington County, detox costs $235 a day. Prior to entering the pilot project, none of the participants were employed in any type of education or training program. Whereas in the first 2 years of the pilot, 67% of the clients are actively employed, enrolled in school, or are volunteering. At the start of the pilot, 60% of the participants were homeless. After 2 years, all of the participants have found housing. All obtained health insurance while participating in the pilot program, and some received treatment for some very serious medical conditions, including COPD, high blood pressure, and one individual needed surgery. Others received psychiatric care for the first time. The Southeast Minnesota CD pilot has similar data. They provided services to 81 individuals since the start of the pilot. And in their pilot, the clients had a total of 221 detox admissions the 2 years prior to admission to the program. 2 years into the program, they've had more than a 50% reduction in detox. In fact, they've had 99 detox admissions. 24 of the 99 were one individual, which obviously does skew their data. 52 individuals had no detox admissions since entering the pilot. Detox costs $326 a day in that region. There have also been significant results in that region regarding housing and employment. 56% of the clients were homeless prior to the pilot. Within the first year, all but one were housed. 4 clients were actively employed when entering the pilot. Now 69% of the clients are actively employed, enrolled in school, or are volunteering. During the last hearing, we had questions about recidivism. And so I have some information about that today. 81 clients in the Southeast pilot had 275 total treatment episodes in the first 2 years in the pilot, compared to 33 treatment episodes while in the pilot. Overall, this is a decrease of 242 individual treatment episodes. 72% did not require any more treatment during the pilot. Lastly, the financial aspect of the pilot. My colleague, Mr. Harder, will be giving you additional information about the financial aspect, but I will say there will not be an increase in state expenditures as a result of this change. We're asking to use the same pot of money more flexibly. We're asking that the commissioner is allowed to restructure payments. Currently, only Rule 31 providers are allowed to receive payment out of this fund. We're also asking that the commissioner can seek waivers from the federal government to include these services in health care, so that our public health care programs will be able to allow these same services. Thank you for the opportunity to testify today and for the opportunity to do this pilot. I am ready for questions.
Well, let me start out, Ms. Rep. It sounds to me like there ought to be savings in the state budget, given the huge decrease in visits to providers.
Well, Mr. Chair, our early data looks like there should be a savings in the system. There also may be savings in other systems, such as jail. There was I didn't get into this in my testimony, but we found in our pilot that there was a huge percentage, at least 75% of these people who are involved in the correctional system.
Representative Liebling, you have a question?
Yeah, thank you, Mr. Chair, and Ms. Rupp, thank you. You know, of course, members of this committee might not all know I carried the pilot previously, and I'm very supportive of this, and I'm just delighted to see the good results and really support this going statewide. But the one little comment I had was that I know in the last committee the word recidivism was used, and I know, Ms. Rupp, you just kind of, I don't want to pick on you, but you kind of picked up that word. And as somebody pointed out to me after the last hearing, that's really the wrong word, because people who are chemically dependent don't recidivate. That's what criminals do, or people who commit another crime. But people who are chemically dependent relapse occasionally. So I just want to say that we want to probably stick to the right language here, because we're talking about something that we all, or I think most people, recognize as being an illness. And chemical dependency is not crime, it's illness, so people relapse, not recidivate. Thank you.
Okay, other questions? Yeah. Yeah. We have a quorum, so I will call the meeting to order, and then Representative Dean has a question, and if there's no other questions, then we'll start the bill, and you can do your amendment. Representative Dean.
Thank you, Mr. Chair. I was going to offer to move the bill if you wanted to do that.
Okay, you could do that.
Offer to do that, and also Just had a question. I'm sorry, the center testifier, I forgot your name. Sorry.
Cindy Rupp.
Thank you. One of the things that we have worked with in chemical dependency and working with the counties, particularly with border counties, you're a border county, is working with neighboring states to provide care in where people live, and sometimes that's not always in our home county. Are we working with our neighboring states and being able to provide treatment, and does this the counties that are involved get into that at all with this program? Do any outreach to, in your instance, Wisconsin, to talk about bordering communities and how we're getting services where we have border communities? Can you chat a little bit about that, please?
Ms. Rupp.
Mr. Chair and Representative, we really have not addressed out-of-state clients in this pilot project, but let me say a little bit more about that. Is that Washington County, for example, does have contracts that the rest of the state uses for 2 out-of-state providers in Wisconsin who have specialty care, let's just say, one who provides mental health care as well as CD. But all counties in the state of Minnesota try very hard to make sure that what we are paying for treatment is for Minnesota residents. But we do have Wisconsin residents who access our providers, and we do access Wisconsin providers. I'm not sure if that addresses your question.
Representative Dean.
And Mr. Chair, and yeah, I think in previous years we've kind of looked at the success rates of people to get care near where they live. And in some instances that has involved working with folks in North and South Dakota, Wisconsin, and Iowa to provide chemical dependency treatment closer to where they live. It turns out it works better and it's cheaper. I was just wondering if in Washington County we're doing that or how it's working, but it sounds like we have agreements with providers on both sides of the river. So thank you.
Ms. Rupp.
Mr. Chair, Representative, that is correct. But your assumptions are also correct that all counties do try to work very hard to make sure that people don't have to go a great distance to receive treatment. And that's part of what the pilot provides, is that when people are finished with treatment, we can provide those continuing supports close to home.
Representative Dean has moved the bill, and I will move the A13-0097 amendment. And Representative Schoen, if you would like to explain the amendment.
All right. Thank you, Mr. Chair, and thank you, Representative Dean. So the A13-0097 amendment is it deletes on page 3 or line 3.1 to 3.9. It just deletes that paragraph altogether. And that came out of some discussion that we had in the policy committee. I think Representative Abler maybe mentioned that. And then the other lines on the amendment basically just shift everything up another paragraph. So I also do have an oral amendment that on page 3 as well, line 3.29, at the end of enrollment in and managed care, delete the period and then add until these services are included in the health plan's benefit set. And I can say that again if somebody needs to. Until these services are included in the health plan's benefit set. And this oral amendment came out of some discussion related to the healthcare plan providers that made them feel a little bit better about their clients and the people they serve as well.
Well, let's deal with the 97 amendment first, and any discussion of that amendment. Representative Liebling.
Thank you, Mr. Chair. And Representative Schoen, I appreciate what you're trying to do here, but my question to this amendment is, so what happens then if a county indeed spends more money one of the phrases you're deleting here is, to the extent that treatment and non-treatment service expenditures within a county's Navigator program exceed the amount expected, in the absence of the Navigator program, the county shall be responsible for the portion of costs for non-treatment services expended in excess of the otherwise expected share of forecasted expenditures. So what I'm asking is, what happens then if costs run over? Is the county in fact going to pick them up, or what happens if we take this out?
Representative Schoen.
Mr. Chair, Representative Liebling, I am 100% prepared to let somebody else answer that question.
Mr. Harder, welcome to the committee.
Thank you, Chairman Huntley. It's an honor and pleasure to be back. And Representative Liebling, that's a wonderful question. And I'll get to some of this in the testimony, but to answer your question specifically, how this was set up in the pilot was that, and how the financing ended up working out, is you have the consolidated fund that's this large. Each county has a maintenance of effort. And what we agreed upon with the department, thanks to their work and efforts as well, was that we would be allowed, each county, within their maintenance of effort portion, to finance these activities, these Navigator activities. Because we didn't want to put any federal money at risk, and we didn't want to mess with the broader pot, if you would, between state funds, federal funds. So we all agreed to say, well, that part which the county's already having to pay, that would be their obligation to fund those Navigator skills. We then, in turn, in the spirit of accountability, said, and if we choose to spend more than that, that's on our dime at the county. And at times that may be worth it because we're keeping people out of detox at $200 and $300 a day. And we're keeping them out of the jail, and we're keeping them out of other places. So removing this actually removes some of the pilot nature and the nuance of it, but actually the paragraph above still preserves, when we talk about funds expected, shared, and of the forecast, that's where we stay within our maintenance of effort.
And Mr. Harder, could you state your name?
I will. Mr. Chair, Kelly Harder. I'm here on behalf of MICA as well. In my day job, I'm also the Director of Community Services for Dakota County. And as a point of reference, I was here 3 years ago when I was a director in Steele County when we were running this bill as well.
Any other questions to the amendment? So, no. Okay, all those in favor of the A13 amendment signify by saying aye. Aye. And opposed? So the amendment is adopted, and then I will make the, what? Okay, Ms. Aves, if you could state the oral amendment that I'm making.
Mr. Chair and members, the amendment should read on page 3, line 29, before the period, insert, until these services are included in the health plan's benefits set.
Okay, any questions about that amendment? Seeing none, all those in favor signify by saying aye. Aye. Opposed? So that amendment is adopted. Now, do we wish to go to Mr. Harder?
Sure. Mr. Chairman and committee members, I just want to start by saying it is really an honor but a pleasure to come back. For some of you who weren't here, 3 years ago, and I last night stumbled upon something that was called the CD Healthcare Home Testimony, April 1, 2009. We talked the name healthcare home off of this bill and ended up with Navigator Pilot. And what was fascinating to me was back then we actually came here, and I think this is a great example of how this is supposed to work, good government, where we had the state willing and legislators, elected officials willing to hear those at the service level, think we want to try something new. We assured that we weren't going to spend more money, and we wanted to improve outcomes, and then you grant us some flexibility to innovate. And thanks to the partnership with the Department of Human Services, who was just wonderful along this journey, because it's not easy changing the way we've always done it. And we know there were risks involved. We came here and I spoke to you about proposing a redesign that would produce overall improved outcomes without increasing costs. And that is exactly what this has proven. We talked about, if you would, in the context of healthcare homes, how do we bring the right amount of care to the person at the right place and time. That's what we're doing with this bill, and it's proving to be a good policy and a good program. We need to increase overall flexibility of the fund, not just have inpatient, outpatient, extended care. This is a subset of a population that's not really, they don't absorb or have a history of absorbing treatment real well, and yet they're in our community and they're costing us whether we want to pay or not, and it's an intervention that has shown to be real effective. And as counties, we said we would assume full responsibility, to Representative's questions early, financially, so that we're vested. We have skin in the game. And along the journey we did go. And in no way did we want to put at risk any of the federal or traditional state funding. And as I go down this testimony list, I was kind of smiling and laughing at ourselves last night to say, check, check, check. And what we're really here to say is, how do we remove pilot off it? How do we allow counties, if they want to opt in, it's not a mandate, that they can. We don't have a real effective tool outside of this to manage this population. And only the pilot counties are in it. So by doing that, you're giving all the residents in the state and the counties an option on whether or not they want to pursue this in partnership with the state. We know we've learned a lot. We still have some tweaking to do. We intend to continue to meet with the department and fine-tune what we need to do with this so they, too, see this. And let me also say that the department has done a wonderful job looking at our whole continuum of CD services and what impact does the ACA have on a population. We used to sit here and talk about eligibility of GA eligible or GAMC eligible. You know, we're not having that talk. And these folks will be seen kind of within the continuum as we do health care. And so when they do relapse, then we have a way that we can most effectively use public resources to meet their needs and prove good outcomes. So we bring you a bill that has foundationally based financially, that it's resilient, it has predictability, and that the amendment we did today also allows some simplification so we don't have this over-wired system or so we don't have to have it more complicated than need be. So with that, it allows, and it's a great framework to have a bill that has resiliency into the future. And with that, I would be willing to ask or answer any questions that all of you might have.
Any questions for Mr. Harder? Representative Grunhagen.
Oh, thank you, Mr. Chair. Yeah, thanks to the testifiers and Representative Schoen for explaining this bill and how it works. What impressed me is that is the amount of relapse, less relapse. So what do you think you're doing in this program differently, or one or two things you're doing that is contributing to the dramatic decline of relapse for that situation compared to other things that we're doing before?
Mr. Chair, Representative, the biggest thing that I see different, having worked in the system many years, is that for these clients, we are assigning a social worker who is called a navigator who works one-on-one with that person. When people leave treatment, typically they have a discharge plan, and it's a good discharge plan, but there are some people who can't follow up on the discharge plan, and those are the people that we tried to capture in the pilot. And so it's a social worker who's going out to their home, who is handing them an application, who is taking them to the psychiatric appointment, because they don't have transportation. And so they're developing a work relationship with that person, providing them the support they need and helping them access resources that exist in the community.
Thank you, Mr. Chair.
Okay. Other questions? I don't see any, so Representative Schoen, would you want to make a final comment?
Well, thank you, Mr. Chair, and thanks for pointing that out, Representative Grunhagen. And what's nice is this program shows that we're saving counties money overall, and then the state overall as an effect. So our taxpayers are doing better as well, even though they have someone with more direct care per individual, maybe driving them around, but that is, in the jails, everything else. This is a fantastic program, and it'd be, if we could find these efficiencies in government all the way around, I think we'd be out of here by April 1st.
Amen.
But this is a great program, and I'd really appreciate your support for this. Thank you.
Okay, well, thank you, Representative Schoen, for your bill, and this bill will be laid over for possible inclusion in the omnibus Health and Human Services Finance Bill. As amended.
Thank you.
Thank you.
And next, we have Representative Schoen, House File 74, and I would move House File 74. And Representative Schoen, your bill.
All right, thank you, Mr. Chair. House File 74 is related to an ambulance rate cut sunset. In the last budget bill, ambulance providers took a rate cut of 4.5% permanently with no sunset date to their medical assistant rate. This language before you sunsets the cut effective June 30th of this year, replacing the 4.5%. I have with me Buck McAlpin, representing the Minnesota Ambulance Association, here to provide some detail of the impact and answer questions.
Mr. McAlpin.
Mr. Chair and members, Buck McAlpin of the Minnesota Ambulance Association. When we looked at this legislation, when it passed in the budget bill last time, we noticed that other providers had a sunset, and our Ambulance Association asked us to bring forward to the legislature to try to replace the 4.5% this year. We saw in the governor's budget proposal, he had 3% for transportation. With the state and federal money, it looks like it's roughly about $3.5 million. The majority of that's in our high-volume EMS systems, but where there is a little bit of an impact is in our rural areas, and even more, our smaller services have a 75-80% Medicare and Medicaid payer mix, and a few $1,000s here and there to them is quite a lot of money. So we kindly request your support to see if this works in the budget bill, Mr. Chair, as you wrap it up at the end of the year.
Questions? Well, I don't see any, so then I will renew my motion that, or no, I will say that this bill will be laid over for possible inclusion in the Health and Human Services omnibus bill. So thank you for your testimony. And Representative Schoen, you have a third bill, House File 2004, and I would, 204, and I would move House File 204. Be recommended to pass. And Representative Schoen.
Thank you, Mr. Chair. House File 204 is before you replaces a 10% medical assistance rate cut to Level 1 trauma centers from the last budget bill. Level 1 trauma centers are unique and require resources that maintain 24-hour-a-day, 7-day-a-week availability of an entire healthcare team from surgeons to nurses. And I have Dr. Kevin Croston, the Chief Medical Officer of North Memorial Healthcare, to answer any questions and provide a brief testimony on what the resources of a Level 1 trauma center are for the state of Minnesota and why they are so important to our healthcare needs.
Dr. Croston, welcome to the committee.
Thank you, Chairman.
State your name for the tape.
It's J. Kevin Croston, MD. I'm the Chief Medical Officer and President of Provider Services at North Memorial. I'm a former chair of the state trauma system as well. I'm not here as their representative tonight, but I am here to speak about Level 1 trauma centers. Level 1 trauma centers and the way our health system has been set up and where our trauma system has been set up in this state is to get patients from the site of injury to their final destination of care as quickly as possible. So part of what we do is try to keep people local that can be cared for locally, and those that can't, quickly identified and moved to the center with the most resources, or at least with the resources that they need in order to receive their care. So the sickest patients are ultimately transferred to Level 1 trauma centers. Unfortunately, in our victims of trauma, a lot of them are uninsured or underinsured, and there's a heavy medical assistance population that's involved in that. If you look at the 4 listed, at least 3 of them stepped up during the CCDS program and have also accepted a disproportionate share of this type of patient over the years. And the resources that are required to provide that level of readiness to manage these patients is not inconsequential. We have to have surgeons, trauma surgeons at the receiving center in addition to emergency department staff, as well as respiratory therapists, nursing, intensive care unit nursing, emergency nursing, et cetera, anesthesiology, subspecialty care available, and they have to be on standby 24/7. Those costs are difficult to do even with a commercial payer, but almost impossible to do without some support. Excuse me. So we're asking to exclude us, the Level 1 trauma centers, from the fee-for-service cut for the 2 years, 2014 to 2016, I believe, and I'd be happy to answer any questions at this point.
So this is, you would be relieved from the cut, but just for the level 1 emergency room services.
For the level 1 trauma centers, right. That's it.
Questions? Representative Quam.
Thank you, Mr. Chair. My understanding is that there is also another level 1 trauma center not on your map? Or isn't Mayo considered level 1?
Yeah, Mayo's included in this.
Are there any other, pardon me, Mr. Chair, are there any others besides Mayo and what's on your map in the state of Minnesota?
Just the level 1s. There's only 4 level 1s. There are level 2 centers out in greater Minnesota, but they're not included in this.
Mr. Chair. Mr. Chair.
Representative Schoen.
So just to specify, maybe this will help. So Hennepin County Medical Center in Minneapolis, North Memorial Medical Center in Robbinsdale, Regions Hospital, St. Paul, and then Mayo in Rochester. Correct?
Correct.
Okay, any further questions? Representative McDonald.
Mr. Chairman, thank you. Question for the testifier and/or Representative Schoen. The cuts were necessary, of course, to balance a deficit, a huge deficit that we had, and we were able to weather the storm and to still provide the services that were necessary to those who were in need, especially in the level 1 trauma centers, and then balance the budget, now have a surplus. Now I see a lot of the bills coming forward to restore some of the necessary cuts to balance a budget. Yet we together as a state came together to solve a crisis and work hard to cut costs and to do our best to save the state money. Now, this year, going forward, there's several bills to restore all those cuts, and yet it was evident the last 2 years we were able to weather the storm and do with what we could with the limited resources and do our very best. It seems though if we get in this continued pattern, we'll be back in a deficit again. So to the testifier, in the last year or so, you were able to still provide quality service, and yet now, going forward, you need more money to do the same service you did in the last 2 years. Could you explain for me, please?
Dr. Croston.
Yeah, I'm sorry. Representative, thank you for the question. 2 things. Healthcare costs haven't deteriorated, and healthcare cost for the urgent emergent type of care that's provided and spoken about with this bill is all we're really seeking. Those are substantial, and they've substantially increased over the last 2 years. Our ability to continue to provide care and be a community safety net, philosophically, community safety net hospital system is incumbent upon our being able to pay for some of this, the cost of providing this service. So the request is really about spending the money where the patients go, as opposed to just looking for a raise, if that makes some sense.
And I would say that, we can balance our budget by cutting MA reimbursement rates. But the providers still have to pay the same cost. We're already underpaying them, so what do? It makes our budget look good, but they just raise their rates to everybody else. So our budget looks good, but somebody else is paying for it. Representative Quam.
Thank you, Mr. Chair. In regards to the latest discussion, my wife is a first responder. Both my sons have been first responders. Most of them also have been with ambulance services. In rural Minnesota, there's emergency. And oftentimes, minutes make the difference in life or death. And down in our area, when Mayo 1, the helicopter comes in, it's on occasions of where if they didn't get to the hospital in level 1 trauma, they would not survive. And with some of the training that goes on, there are new techniques, new equipment, etc. So for level 1 trauma, it's in many cases a cutting edge area, and you can maybe push off updating and etc. some of the expenses, but I think it's one of the areas that would need watering, so to speak, more frequently than other areas. And so I do also agree that they were able to handle, but I think when we're looking at the different areas of the budget in HHS, some areas that maybe are mainstream, decades-long practices or, fairly common technology can keep the same equipment and training, but there are other areas where the expiration date is much shorter on the training, the resources, and et cetera. And so I would, personally see this as an area that has a shorter runway to be able to sustain, long-term, constrictions. That's not to make a comment that, the funding is appropriate, just that this area probably, should be towards the front of the line when it comes to, looking at when we restore funds.
Representative Gruenhagen.
No,
Oh, you were, okay. He did your,
well, he's got another question that I was going to ask him.
Representative McDonald.
Well, thank you, Mr. Chairman. No, I had a follow-up, actually, to Representative, the author of the bill with the fiscal note. And this is, of course, crosses party lines. I think this happens with the fiscal note, but we see an increase. There's an increase for the fiscal year 15. We all recognize the cost of living and the inflation, but close to almost $1 million more for 2015 when we're restoring those cuts from 2011 and 12. And I just think as policymakers, lawmakers, we ought to be more cognizant of the fact that it's easy to have a fiscal note and we say, well, that's just the way it is. We're going to spend another $1 million the next year, or whatever the number may be. So I think it's just, I'd like to have the author quantify just those costs that increase from 2014 to 15, and then the decrease I see on the fiscal note for 2016. I'm a little perplexed on that.
Representative Schoen.
Mr. Chair, Representative McDonald, I won't pretend to understand exactly right off the decrease from, but if the research staff has that, I think I would certainly defer to the extreme expertise
Mr. Berg.
on that number. And then I could speak to some other piece of it.
Mr. Chairman, Representative McDonald, if you look at the fiscal note, well, first, to the second part of your question, why it goes down in 16, this ends at the end of 15, fiscal year 15, and so what shows in 16 is just really a cleanup payment because of our delayed payment schedule. So, but the service provision date ends during fiscal year 15, so that there wouldn't be any continuing payments. But if you look at the increases and you go to page 3 of the fiscal note, really, and look at the inpatient hospital base numbers for each of the groups there, you'll just see that the inpatient, that the numbers are higher, projected to be higher number of patients in 15 than there were in 14, but that the discount is applied as the same, but it's being applied to what's assumed to be more patients. So that's why it goes up. It's not an inflation factor, it's because they assume there will be more patients.
Representative McDonald, does that answer your question?
That suffice it to say it does, yes, especially when Mr. Burke explains that the program does end, so that seems to make sense. Certainly, in the event that it doesn't, the numbers don't increase for 2015 then, and we hope to God that they don't, really, right? Then what happens to the financial dollars? Do they just not get allocated, Mr. Burke?
Mr. Burke.
Mr. Chair, I'm sorry, could you restate? I was talking to John, so I didn't catch the first part of your...
Sure. Well, this could apply in many things across the board in the state, but in perhaps, I'm asking a question that I should know, but in the inpatient, in the projections for 2015 or 16, they're increasing. So we hope that they don't, of course. So in the attempts, if it doesn't increase to those numbers, does the money then just not be issued? The increase for that cost?
Mr. Berg.
Mr. Chair, Representative McDonald, there are a number of programs in this committee, primarily the biggest one being medical assistance, that is what we call a forecasted program. And twice a year, this Thursday is the February forecast, the Department of Human Services and Minnesota Management and Budget make a forecast of what they think usage of the various forecasted programs will be during the planning horizon, which now is 14, 15, 16, and 17. And so twice a year we update that. Sometimes it goes up, sometimes it goes down. that affects the state budget. We do actually appropriate those dollars, but in the general fund balance, we assume that forecasted programs will get appropriated. If that answers the question.
Mr. McDonald.
No further questions.
Any other questions? Then I would move, Representative Schoen, do you have a final comment?
Sure, Mr. Chair, and I appreciate what Representative McDonald was saying about, we had to tighten our belts. There's no doubt about it. And, I suppose if we look at a level 1 trauma center like a home, we get a roof over our heads at home, but we sometimes look at the shingles and go, this isn't the best year. We're going to wait a couple years. And a level 1 trauma center isn't looking at shingles. They're looking at innovation and research and how are we going to save one of our family members. And that gets put on hold, and that's the piece. And just from my own personal experience, work-wise, but when I was in first grade, my dad was involved in a head-on motor vehicle crash right in the middle of harvest. And he laid in, I think it was Hennepin County Medical Center for 30 days or around that time unconscious. And he's still alive to this day because of that, because he got to the right place. And this is west central Minnesota. So, I mean, it's not like it's right next door, but that's where he needed to be. And I'm very appreciative of what happened from my own personal standpoint, because I still get to tell my dad I love him every day, right? And so I appreciate what these folks do. This is a pretty important piece to our society and our healthcare system as a whole. And this is certainly one area we want to see innovation grow, and every piece of technology, because every year more people live because we're doing a better job in trauma care. So I thank you for your support.
Okay, any other questions? I don't see any, so this bill will be laid over for possible inclusion in the Omnibus Health and Human Services Finance Bill. And before we get to the last bill, would somebody like to move the minutes of the February 19th meeting?
So moved, Mr. Chair.
Representative Loeffler moves the minutes. Any discussion? Seeing none, all those in favor signify by saying aye. Aye. Opposed? So the minutes are approved. And Representative Fritz, would you like to chair?
Yeah. We're going the opposite way. So loosen your wallet up for the one. You are a rich
Representative Huntley, welcome to your committee.
Madam Chair, I would like to move House File 380. And this is, and it should be sent hopefully to the General Register. This is really just a technical correction. We had approved a one-time payment for a study, and that involved this, well, anyway, I don't think I have the...
You have a testifier, Representative Huntley?
Oh.
Okay.
This was an uncompensated care study, and it was a one-time payment of $10,000 to pay for the study, and when it got put into law, it was not clear that it was a one-time study, so this just says that it was a one-time study, so it is not an ongoing expense.
Thank you, Mr. Chairman, and I understand you have someone to speak
If
to it,
there's
or-
questions, Mr.
Okay.
McAlpin can answer them.
All right, committee, any questions? Not seeing any. All in favor of sending this on to the General Register, please say aye.
Aye.
Opposed, nay? Ayes have it. It will be going to the General Register.
I guess.
And members, I do want to bring your attention to a group of students, 9th and 12th grade students from Arcadia Charter School. If you'll all join me, they're from Northfield, Minnesota, my hometown. If you would join me in welcoming them, welcome. Conclude the business. Would you want to take pictures?
Yeah.
We're adjourned. All right, members, thank you again for your coming and your participation, and we are adjourned.